Dr. Bak simply explained the lung disorder in two ways. There's two different types of lung disorder. One is sick lung. My lung is sick. I was smoking a lot, and I have bronchitis. I have asthma. Your lung itself has problems. But the other lung disorder is lung is very healthy, but your muscle, which is bring the air in, the respiratory muscle is very weak. Diaphragm is also muscle that is also very weak. Sometimes you have a scoliosis, and then that makes your rib cage is very small, limited. So we call that restrictive type of lung disorder. Those patients, their lung is very healthy. So some reason they all have a tracheostomy. They have oxygen. And then I get really fascinated by this, all the physicians care. My colleagues, they give oxygen no matter what happened. All of a sudden, if patients start to have some breathing problems, everybody on oxygen. And then they feel comfortable. They means physician, they feel comfortable, not the patient. So physician, they are treating by themselves, not for the patient. So, and also there is the distinctive two different symptoms and signs we can understand from two different lung disorder. So if you have asthma or bronchitis, your symptoms is more oxygenation problem, right? Your lung has a problem, so you need oxygen. So you're going to require more, like you have more problem with the shortness of breath. You have difficulty with the breathing first, that's the first sign. But you have a problem with the outside of the lung, muscle weakness, scoliosis, in neuromuscular disorder patient like Pompe or Duchenne muscular dystrophy. Those patients, initially, they don't feel that much shortness of breath. Their symptoms are more tired, morning headache. Sometimes one of my patients was complaining, something stuck in my throat. They went to gastroenterology forever. They couldn't figure it out. Later, we started giving non-invasive ventilator. The symptoms completely disappeared. So that was from the hypoventilation, breathing shallowly at that time. So later, but finally we need some oxygen because the chronic CO2, carbon dioxide accumulation, is going to require some oxygen. So there's some difference. So initially, shortness of breath is going to happen to the patient who has lung disorder. The patients, just like in this group, Pompe or neuromuscular disorder patient, initially they don't have that feeling. They have more depression, fatigue, nightmare, kind of different symptoms first. So once again, we have obstructive lung disorder. On the left side, just asthma, bronchitis, bronchiolitis. Those patients have sick lung, but healthy muscle. Their muscles are healthy. So they're going to have oxygenation problems, and it's going to cause pulmonary, primary hypoxia. They need oxygen first. So we give oxygen. That's perfect treatment. And you can give bronchodilator. But if the patient has restrictive lung disorder, you're going to have a problem with weak muscle, but healthy lung. And then we're going to need some more ventilatory aid. Something, my muscle needs to be stronger, or I need some aids for that. And then they're going to have more problem with CO2, carbon dioxide accumulation. So if you give, so your lung problem has been very chronically accumulated problems. I have one patient on the floor. That morning, I was only one attending. It was 7 o'clock in the morning. I was making rounds by myself. One of the nurse was calling me, Dr. Kim, there is one patient, code blue. Baby cannot breathe. So I ran to the room. I thought that's somebody else's patient because I'm a rehabilitation doctor. I shouldn't have any emergency. I ran to the room. That was my new patient from last night. The patient had spinal muscular atrophy. And then the patient had spinal fusion. And then the orthopedic surgeon put the the trunk. So her muscle got weaker than before. And she had chronic CO2 accumulation. Nobody knew. So I was ambu begging and I sent blood gas. Even the doctor back said, don't send blood gas, but I had no choice. I had to do arterial blood gas, and I shipped her out to the intensive care unit. And later I got the report. Her CO2 was 92. What if we gave the oxygen? She could have died in front of me. So you cannot give oxygen. You always have to go to, whenever you have to go to the emergency room, you have to make sure you are not having oxygen until they give the ventilator support by some ambu bagging or a ventilator application. So the Pompe disease, just like what we talk about, you have a healthy lung, but you have a weak muscle, which is bring the air in and out. So now I'm going to talk about invasive, non-invasive ventilatory care. So why we are saying that you shouldn't have a tracheostomy? We are not really saying that actually. You can have it, but you don't need to have that forever. I'll give you one example. I had 3 Duchenne muscular dystrophy patients from same family. And 2 other cousins, they had they are very significant stages, but they were not on the ventilator. They didn't have a trach. But youngest one, progress is very fast. So he had a trach. So when I checked his vital capacity, it was like 1 liter. I thought he can be off the ventilator. So I was trying to close his trach. That's what happened. My patient became panicky. He said, Dr. Kim, you are closing my airway. You are killing me. He started to hyperventilate. So we had to put the MV back again, and I have to reconnect the tube. But patient has been well trained by a physician. They said, this is your airway lifeline. You cannot close. That's all we made the mistake. Physician made the mistake. So we're going to talk about invasive and non-invasive ventilatory care. So this little girl I saw in Dubai, in Middle East, they don't have non-invasive treatment idea at all. So mom wants to bring her to home, but they cannot control anything at home. So she has to live in the hospital forever with this trach. And they want to close, but they don't know how to close. So we were working with anesthesiology at that time. Anyway, so it's very easy for you to access the airway. But the problem is, once we put the foreign body, it can cause more secretion, right? And then even though you put the regular suction, you cannot really get rid of thick mucus at all. And then for you to get rid of this mucus, you have to have about 85% of total lung capacity of power to get it out. So even the little suction, every 5 minutes you do suction, you cannot do anything, actually. So, and also you're constantly giving the stimulation, so you can have subglottic stenosis. And as you put the tube for a long time, the dislodging happens. So it's more and more dangerous. So some point they need a trach, emergency case, so we don't say no. If you have to go to the emergency room for some reason, if you have to put, they have to put the trach, let them put it. But later, let them close.